Chapter 9 is sexual disorders, gender dysphoria, and paraphilic disorders. So, when it comes to sexual and gender identity disorders, we first need to think about what the difference is between what's considered normal versus abnormal sexual behavior. So, we're going to speak in terms of facts and statistics, also cultural considerations, and gender differences in sexual behaviors and attitudes that have persisted throughout our society. And if you take a look, at the chart right in front of you, you can see the percentage of males and females from ages 25 to 44 who have had each of the types of sexual contacts in the United States in 2002. So, any opposite sex contact, any oral sex with the opposite sex, and then same sex contact. You can also see a vaginal intercourse and then anal sex with the opposite sex. So this speaks to our 2002 statistics regarding these criteria. So when it comes to the development of a sexual orientation, there's an interaction between biological, psychological, and social factors. For example, homosexuality has been found that there's only a small genetic component, about 50% of identical twins that are raised together with the same genes, same environment, do not share the same sexual orientation. In the DSM 5, it looks at disorders and sexuality and gender in terms of gender dysphoria, sexual dysfunctions, and then also paraphilias. For sexual dysfunctions, these are going to be situations that are not typical that involve issues regarding desire, arousal, or orgasm. It can also be associated with pain during sex, which can also lead to additional dysfunctions. When a person has a sexual dysfunction, it must be symptoms that are present for at least 6 months in order to be diagnosed. It also must lead to impairment or distress in order for it to be considered a disorder. The prevalence rates of sexual dysfunctions are extremely common and may not be distressing. For example, there was a study done that said that 40% of men have some difficulties with erection and ejaculation. 63% of women have had problems with arousal and orgasm. So males and females are experiencing these parallel versions of these sexual dysfunctions, but people don't oftentimes talk about it or receive treatment for it. So when we classify these sexual dysfunctions, we're going to classify them in terms of whether or not they're lifelong things or things that are acquired with age, whether or not they're generalized or situational, whether or not they have to do with psychological factors alone, or if it's some type of psychological factor that's due to medication or a medical condition. So, one such disorder is male hypoactive sexual desire disorder. This occurs when a male has little or no interest in any type of sexual activity. Masturbation, sexual fantasies, and intercourse are very rare for these people with male um, hypoactive sexual desire disorder. It accounts for half of all complaints at sexual clinics and is extremely rare, typically affecting about 5% of men. Here are the DSM criteria for male hypoactive sexual desire disorder. Remember, those symptoms must be present for at least 6 months. And then we also have female sexual interest arousal disorder, which involves a lack of or significantly reduced interest in sex or being aroused. This typically manifests itself in reduced sexual interest, reduced sexual activity, fewer sexual thoughts, reduced arousal to sexual cues, reduced pleasure or sensation during almost all sexual encounters. And here are the DSM criteria for female sexual interest arousal disorder. And those remaining criteria. Another common sexual disorder is female orgasmic disorder. This involves a marked delay or absence or a decreased intensity of orgasm in almost all sexual encounters. It's not explained by relationship distress or any other type of significant distressors, like, not getting along with a partner or anything like that. This is a delay or absence or a decreased intensity of orgasm. It typically happens in 1 to 4 women who have significant difficulty in achieving an orgasm. Here are the criteria for this disorder. It's going to occur in most all occasions for at least 6 months. Okay, so the next sexual disorder we're going to talk about is genitopelvic pain penetration disorder. This also occurs in females when there's difficulty with vaginal penetration during intercourse, and it could involve pain during intercourse, fear or anxiety about having pain during sexual activity, or tensing of those pelvic floor muscles in anticipation of sexual activity. Here are those DSM criteria for genitopelvic pain penetration disorder. Here are the rest of those criteria. Another common disorder, which is prominent in males, is premature ejaculation. This occurs when ejaculation occurs within 1 minute of penetration before it's actually desired. This is the most prevalent sexual dysfunction that occurs in adult males. It typically affects 21% of adult males, primarily in the younger, more inexperienced males who are having many of their first sexual encounters. But those problems tend to decline with age, with experience, also with being with the same partner for a while. So that lack of anticipation. Here are those DSM criteria for premature ejaculation. Another disorder is erectile disorder, and this occurs when a male has problem achieving or maintaining an erection. Their sexual desire is still there, and it's also one of the most common presenting problems for men who seek treatment, especially men over 60, or as they age. Over 60% of men over 60 experience erectile dysfunction. You can see there from the chart kind of how, as men age, it becomes a lot more intense. So when we assess sexual behaviors, we have to take a comprehensive interview. So people have to talk about their sexual behavior, their lifestyle, anything associated with them. They also have to undergo a medical examination to rule out any type of medical causes to their sexual dysfunction. There's a psychophysiological evaluation where they are exposed to erotic material to determine the extent and pattern of their sexual arousal. For males, their erections are measured, and for females, the blood flow to their vaginal walls to indicate their levels of arousal can also be measured to determine how their body is responding in a sexual way. So when we think of sexual dysfunctions and we think of what causes these things, we know that there are some biological contributions. It could be disease, medical condition, prescription medications, also using alcohol and other drugs, having anti-hypertension medication as well. So there are some psychological contributions. People with sexual dysfunctions are more likely to experience anxiety and negative thoughts about their sexual encounters. They may actively try to avoid awareness of sexual cues so that they don't have to respond in a sexual way. For example, men with premature ejaculation tend to distract themselves to avoid having an orgasm, which could lead to less control. And then also there's some psychological profiles that can be associated with sexual dysfunctions. From a social and cultural standpoint, you can have learned negative attitudes about sexuality. If someone has had negative or traumatic sexual experiences, such as rape or molestation, it might impact their sexual functioning. Not having good interpersonal relationships or not having good communication can also play a role. When it comes to how we treat sexual function disorders, we're going to look at education, and that can be effective. Masters and Johnsons are the two researchers who were the gurus of um, sex therapy, and they did a lot of research where they educated clients about how their bodies respond sexually, and they gave them homework, and they helped them work on foreplay and how to please one another. They did some sensate focus and non-demand pleasuring to help increase levels of arousal, and it tended to work for couples, because most of their work was with couples who were going through sexual desire and sexual intimacy issues. But the goal was always on sensations and trying to increase arousal and level of orgasm and decrease those performance anxieties that people might have. There's also a few other psychosocial procedures that have been found to be effective for sexual dysfunction disorders, and those things, the squeeze technique has been effective for premature ejaculation. Masturbatory training has been effective for female orgasmic disorder. The use of dilators have helped with vaginismus, and having exposure to erotic material could help with individuals who are suffering from low sexual desire problems. There are also some medical treatments we can have for those sexual dysfunction disorders. Drugs like Viagra have been found to be effective with erectile dysfunction, but there are some side effects. So many times people will discontinue use. Increasing levels of testosterone or other injectable drugs into the penis have also been found to be helpful. Having surgeries, going through vacuum device therapies as well. There are a few medical procedures that are going to exist in the same way that work for female sexual dysfunction disorders. Now we're going to switch gears a little bit and talk about some paraphilic disorders. So, paraphilic disorders occur when a person has misplaced sexual attraction and arousal. So, a person could engage in a paraphilic disorder when they focus their sexual desires on an inappropriate person or an object. It often involves multiple paraphilic patterns of arousal. There can also be high comorbidity with anxiety, mood, and substance use disorders. So, according to the DSM 5, there are a number of different paraphilic disorders, and you can see all of those listed here. We'll discuss each one. These disorders are often caused by fantasies, urges, arousals, or behaviors. Um, Paraphilias are not always considered disordered. They're only considered disordered when the individual experiences a clinically significant level of distress or impairment, or they act on an urge with a non-consenting person. So the first paraphilic disorder we're going to discuss is a fetish disorder, and this involves sexual attraction to a non-human object. So, like an inanimate object or something that's tactile, like rubber, feet, shoes. Here are the DSM criteria for fetishes. The next disorder we're going to discuss is frotteuristic disorder. This involves a persistent pattern of seeking sexual gratification from rubbing up against a person who's unwilling. This could be very problematic. It occurs often in crowds or confined spaces where people can't escape, such as like an elevator or a subway, a concert. Here are the DSM criteria for frauderistic disorder as well. We also have voyeuristic and exhibitionist disorders. Voyeurism typically involves observing an unsuspecting individual as they're undressing, naked, or engaged in sexual activity. There's risk associated with this because it often involves like peeping, which may intensify the sexual arousal. And then exhibitionism involves exposure of the genitals to an unsuspecting stranger. And there's also an element of thrill and risk that's associated with it for sexual arousal. So obviously, these are two disorders that could lead to jail or a lot of negative things for a person who experiences it. Here are the DSM criteria for both of those disorders. Notice you must be at least 18 years of age. The next disorder is transvestic disorder, and this involves sexual arousal with the act of cross dressing. Males may rarely show highly masculine compensatory behaviors, so they're not going to do a lot of things that are particularly masculine. Many people who experience this disorder are married, and the behavior is often known to their spouse. This disorder is one of those that's not inherently pathological. It may not be considered a disorder. It's only considered a disorder if it causes significant distress or impairment. So if somebody has transvestite disorder and their spouse knows about it and is okay with it, it's not considered a problem. If they're able to lead a normal life and it doesn't cause them any issues, then it's not considered a problem. Here are the DSM criteria for this disorder. We also have sexual sadism and sexual masochism disorders. Sexual sadism involves inflicting pain or humiliation to attain sexual gratification. Sexual masochism involves suffering pain or humiliation to attain sexual gratification. And once again, both of these disorders are going to be something that is only going to be a problem if there's somebody who's non-consenting involved. If a person is with a partner and the partner is okay with having pain inflicting on them or giving pain, then it's generally not considered an issue. Here are the DSM criteria for sadism and masochism. Here are the rest of those criteria. Now, it's important to note that when it comes to sadism, paraphilia, and rape, some rapists might be sadists, but most are not. Many rapists do not show paraphilic patterns of arousal, and rapists tend to show sexual arousal to violent, sexual, and non sexual material. I don't want you to get the wrong idea that these things are necessarily always associated with each other. And we also have paraphilic disorder, and this occurs when a person has sexual attraction to prepubescent children, which of course is a big problem. The vast majority of sufferers of pedophilic disorder are males. It's not unheard of in females, but it's very rare. In many cases, people with pedophilic urges often engage in incest, in sexual activities with their own family members. Many people who have this disorder don't actually act on their desires, and they realize that their urges are wrong. Incestuous males may be aroused by adult women. Male pedophiles are usually not aroused by adult women. And some people with pedophilia can rationalize their behavior by saying that it's an act of affection or a teaching experience. And we know, of course, those things are are not right, and other people often engage in moral compensatory behaviors. So, when it comes to the causes of paraphilic disorders, it could be because of difficulty forming normal relationships. So, deficits in typical sexual experiences, relationship difficulties in childhood or adolescence. Early experiences could also lead to sexual associations by chance, and they could be reinforced through masturbation. It could be due to having a very high sex drive and suppressing those unwanted fantasies by paradoxically increasing them. And when it comes to treatment, most treatments are going to be behavioral. They're going to target defiant and inappropriate sexual associations. There could also be some covert sensitization. So imagining aversive consequences to form those negative associations. Having orgasmic reconditioning, so masturbation to appropriate adult stimuli, so that desire for non adults is not there. Engaging in family and marital therapy can also help address some interpersonal problems, and having coping and relapse prevention so that the person learns some self control and risk management can also be helpful. When it comes to the efficacy levels of those treatments, especially when it comes to sex offenders, about 75 to 95% of cases show improvement. The poorest outcomes are often involving rapists or people with multiple paraphilias, and they tend to run a chronic course with high relapse rates, which is not good. We can also have some drug treatments, and these are going to be drugs that are similar to chemical castrations, and those are often used for very dangerous sexual offenders. There are a number of different medications that can also be given to reduce testosterone levels and to reduce sexual urges and help reduce those desires that people might have. If a person tends to go off these medications, however, relapse is often common. Now, let's talk a bit about gender dysphoria. Gender dysphoria occurs when a person feels trapped in the body of the wrong sex. There's a desire to assume the identity of the desired sex. It's not something sexual, it's feeling like you were born the incorrect sex. The gender identity is thought to be developed between 18 months and 3 years of age. And there could be fluid or cross gendered identity, which is not a disorder. It only becomes a disorder when it causes distress or significant impairment. So, here are the DSM criteria for gender dysphoria in children. And here are the DSM criteria for gender dysphoria in adolescents and adults. And notice there's difference between children and adolescents and adults. So we generally think that there are some children who might feel that way as children and then eventually grow out of it, and some people who might develop gender dysphoria later. So there are a few ways we can treat it. One is a sexual reassignment surgery, which must be psychologically, socially, and financially. A person must show stability in those areas and a desire to live as a desired gender for several years first. 75% of people report satisfaction with their new identity after sexual reassignment surgery, and female to male conversions tend to adjust better. This is very controversial treatment, especially when it comes to transgender behavior in children. There have been a number of children who have undergone surgery and not been okay with it in the long term. When it comes to treating intersexuality, this is often treated with surgery at birth, and there could be subsequent gender dysphoria, which may need to be addressed. And this, of course, occurs when basically doctors are deciding which gender needs to be appropriate. So, to summarize, sexual and gender identity disorders. Sexual dysfunctions are very common. There could be a problem with desire, arousal, or orgasm. Those paraphilic disorders represent inappropriate sexual attractions. There could be some psychosocial and medical treatment options that can be helpful. There are also some comprehensive assessments and treatment approaches that are best. When it comes to gender dysphoria, a person might feel trapped in the body of the opposite sex, and they may desire to live their life as a different gender. So I hope that by going over this helps all of you guys understand a little bit more about sexual dysfunction and gender identity disorders.